All right, so a very good evening, everyone. So, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. So, now in this session, this will be a short session. This will be just a session of just 30 to 40 minutes. In this particular session of emergency medicine, I'll just quickly go through the clinical features and as well as management of the commonly used drugs. It is not like all the drugs I'll be discussing. So, like I'll try to discuss some of the questions which have been asked previously, like on the topic of drug overdosage and as well as treatment from the emergency medicine point of view, right? So, having said this, 1 minute, I'm sorry. Right. So, what exactly is the drug of choice for the phenylephrine overdose? The options are phentolamine, propranolol, metoprolol, nadolol. Right. Any one of you, please? Right. Now, let me discuss the phenylephrine overdose. Now, what exactly is your phenylephrine? The phenylephrine, it is nothing but a sympathomimetic drug, right? It is a sympathomimetic drug. Now, let me discuss what will be the examples of your sympathomimetics and what will be the mechanism of action and what will be the clinical features and as well as the treatment point of view. Right. Can anyone answer now? Yes. Right. So the correct answer, very good. So the drug of choice will be the phentolamine. Right. The drug of choice will be the phentolamine. Now, if you take this particular discussion, just give me a minute, 1 minute. Some technical issue, 1 minute. It will get resolved. Okay. Right. So if you take this sympathomimetics, like what are all the sympathomimetics? Like we have the alpha 1 adrenergic agonist and as well as the beta 2 adrenergic agonist. Now, what are these? The alpha 1 adrenergic agonist, like we have the phenylephrine and as well as the phenylpropranolol, right? These are the alpha 1 adrenergic agonists. And what are your beta 2 adrenergic agonists? These beta 2 adrenergic agonists are mainly the bronchodilators like albuterol, terbutaline. These are the beta 2 adrenergic agonists. Now, what is the mechanism of action of these particular group of drugs? They cause the stimulation of the central and as well as the peripheral sympathetic receptors, right? Stimulation of the sympathetic receptors. Okay. And what are these sympathetic receptors? That is your alpha 1, alpha and as well as beta receptors. Now, the clinical features will be in the form of the physiological stimulation. Now, what do you understand by this word? The physiological stimulation is these individuals, they'll have the following features. That is the physiological stimulation, where depending upon the severity, they can have the anxiousness or agitated, or they may go into a state of delirium, and they may finally land up in coma and as well as seizures. These are the features of the physiological stimulation that you can have because of sympathomimetic overdose. Now, what is the specific treatment? Right, what will be the specific treatment in case of sympathomimetic overdose? So either you take this phenylephrine overdose or phenylpropranolol overdose, like the drug of choice will be the phentolamine. And what is this particular phentolamine? Phentolamine, it is a non-selective alpha 1 adrenergic receptor antagonist, right? Basically it's a non-selective blocker. Which one? The phentolamine. And what are the other drugs that can be given is the propranolol. See, propranolol is what? It's a non-selective beta blocker that is mainly given for hypotension and as well as tachycardia. So if the individual is having beta 2 agonistic overactivity, then we give this particular propranolol. And the other drug is metoprolol. Metoprolol, it's a cardioselective beta blocker. Mainly if the individual is having tachycardia, then we give this metoprolol. So these will be the features of your sympathomimetic overdose, right? So if the question is being asked what is the drug of choice for phenylephrine overdose, that is the phentolamine. Next, the other group of drugs which are very commonly used, okay, not being very commonly used, one of the frequently asked question as well. Which of the following drug is not preferred, right? Which of the following is the drug which is not being preferred to prevent the development of gangrene due to ergot overdose? Due to ergot overdose. Sympathomimetics, nitroglycerin, nifedipine, prazosin. Which of the following drug is not being preferred? Any one of you? Right. Now, let me try to explain to you. No. No, it is not nitroglycerin. Now, okay, let me tell you about the ergot overdose. So now, what are your ergot alkaloids? The ergot alkaloids, these are all the examples of the ergot alkaloids. What are those? That is your ergotamine, methysergide, bromocryptine, and pergolide. Now, what is the mechanism of action of these ergot alkaloids? They cause the stimulation and inhibition of the serotonergic and as well as the alpha adrenergic receptors. Right? Stimulation and inhibition of the serotonergic and alpha adrenergic receptors. And what is the mechanism of action of these particular ergot alkaloids? Please remember, right? Please remember, they will induce vasospasm of the limb. Right? They will cause physiological stimulation and they will cause the vasospasm of the blood vessels supplying to the limb. And not only that, they will also cause myocardial and as well as cerebral ischemia. Now, for ergot alkaloid overdose, what are the drugs that we can give? We should give the drugs which will inhibit that vasospasm. What are those? Nitroglycerin is considered as one of the drugs whenever there is severe vasospasm. The other one is the prazosin, right? What exactly is your prazosin? It's an alpha blocker. That is also the drug which can prevent the vasospasm. And the other group of drugs will be the antipsychotics. So this particular antipsychotics are given for hallucination and as well as movement disorder that occurs because of the ergot alkaloid overdose. So now the drug, yeah, you can see this question. So now tell me, which of the following drug is not preferred to prevent the development of gangrene due to ergot overdose? Sympathomimetics, nitroglycerin, nifedipine, prazosin. So the correct answer here will be the sympathomimetics. Why? Because the sympathomimetics will further induce the vasospasm. Right, will further induce vasospasm. Now, what is your nifedipine? Nifedipine it's a calcium channel blocker. Nifedipine is the calcium channel blocker, and this particular nifedipine can be given because this nifedipine, it can inhibit the vasospasm. So nitroglycerin, nifedipine and prazosin can be given, that is to prevent the development of the vasospasm and gangrene. But sympathomimetics, if you give, they will further precipitate the vasospasm and they will induce the development of gangrene in case of the ergot alkaloid overdose. Okay, so this is one of the important PYQ which was asked on the drug overdose. Right. So this is another question which has been asked on the drug overdose. What is the drug of choice for methylxanthine overdose? The options are the esmolol, phentolamine, nitroglycerin, antipsychotics. Drug of choice for the methylxanthine overdose. Now, if you take this methylxanthines, what are the examples of the methylxanthines? The examples of your methylxanthines, they are mainly theophylline, and the other important drug is the caffeine. And you should know the mechanism of action of these methylxanthines. The mechanism of action of these methylxanthines, they include, number one, they cause the inhibition of the adenosine receptor. And not only that, they cause the stimulation of epinephrine and norepinephrine release. So stimulation of epinephrine and as well as the norepinephrine release. Now, what will be the clinical features? They will have the physiological stimulation. They can have the gastrointestinal symptoms. These will be the clinical features because of methylxanthine overdose. Now, because of the physiological stimulation due to methylxanthines, the individual can develop tachycardia. And for tachycardia secondary to methylxanthine overdose, the drug that we give is the esmolol because it is a short acting as well, right? And the other important drug will be propranolol. So esmolol and as well as the propranolol, but preferably the esmolol is being used, right? Now, what is the indication of the hemodialysis in case of methylxanthine overdose? See, theophylline level, when it is more than 800 to 100 micrograms per ml, that is the point when the individual can develop seizures. So whenever the individual develops seizures due to methylxanthine overdose, that is the point when we do the hemodialysis. So if you see the question now, which of the following is the drug of choice for methylxanthine overdose? The drug of choice will be your esmolol. Now, what is the purpose of giving the esmolol? The esmolol we are giving mainly to reduce the tachycardia because this theophylline or caffeine, they cause a physiological stimulation causing tachycardia, and we want that particular tachycardia to be reduced, and for which we give esmolol. So the drug of choice is the esmolol. What are the other options? Phentolamine, which is an alpha blocker which is given in the treatment of hypertension. Nitroglycerin, also the one which will inhibit the vasospasm and will reduce the hypertension. Antipsychotics, no way useful in the treatment of methylxanthine overdose. Okay, so that is about the treatment of methylxanthine overdose. Next, then followed by that, yes, this is another important, the PYQ which has been asked, right? What is the drug of choice for selegiline overdose? The options are bromocriptine, sympathomimetics, esmolol, doxophilin. Drug of choice for selegiline overdose. Now, you should understand what exactly is this particular selegiline come under. So, we have monoamino oxidase inhibitors. Now, what are the examples of your monoamino oxidase inhibitors? One is phenelzine, then selegiline. These are the two drugs, phenelzine and the other one is selegiline. These are the two drugs which comes under your monoamino oxidase inhibitors. Now, what is the mechanism of action of these monoamino oxidase inhibitors? Okay, so yes, many of you answering as the A. Now, let me discuss and then come back to this particular question again. Now, if you take these monoamino oxidase inhibitors, right, what is the mechanism of action of these particular drugs? They cause inhibition of monoamino oxidase enzyme, and that will result in impaired metabolism of the endogenous catecholamines. So what is happening to the levels of your catecholamines? There is increase in the levels of the endogenous catecholamines, right? Now, what will be the clinical features? Same thing, physiological stimulation. What do you understand by the word physiological stimulation? That is agitation, delirium, tachycardia, vasoconstriction, hypertension. These are all the features of the monoamino oxidase inhibitor overdose. So basically, what they will do is they will increase the epinephrine and as well as the norepinephrine overdose. So for which, what are the drugs that are being given? If the individual develop tachycardia and severe hypertension, again we give the short acting agents, and that particular short acting agents is nothing but the esmolol. That is nothing but esmolol. So please remember, even in case of monoamino oxidase inhibitors, methylxanthines, the drug of choice will be esmolol. Please remember this. Okay, so the answer here will be the esmolol. It is not your bromocriptine. It is not your bromocriptine. It is your esmolol. And what is the purpose why we are giving esmolol? Because this monoamino oxidase inhibitors, they will cause impairment of metabolism of endogenous catecholamines and thereby increasing the epinephrine and norepinephrine, causing hypertension and tachycardia. And in order to reduce that hypertension and tachycardia, we give this particular esmolol, which is considered as the drug of choice. Okay, right. Now, next to this monoamino oxidase, see, we have discussed until the four important group of drugs. One is your sympathetics, that is your sympathomimetics, ergot alkaloids, methylxanthines, and monoamino oxidase inhibitors. In all these four classes, whatever we have discussed, there will be physiological stimulation. That means there will be tachycardia, hypertension, agitation, delirium, anxiety. So in all of these group of drugs, we need to give the drugs which will reduce the sympathetic activity. In case of sympathomimetic overdose like phenylephrine, what we were giving phentolamine as a drug of choice. Ergot alkaloids, what is the drug of choice? That is, what are the drugs that are being preferable? Again, it's an alpha blocker, prazosin or nitroglycerin or nifedipine. Methylxanthine overdose, esmolol. Monoamino oxidase overdose, esmolol. Okay. Now, after having discussed about the sympathetics, now let me discuss the anticholinergic group of drugs. Okay, you see this question. What is the drug of choice for doxylamine overdose? drug of choice for doxylamine overdose. Now for that you need to understand which group of drug is your doxylamine. Which group of drug is your doxylamine? So your doxylamine, please remember, it is an antihistamine. Right, it is an antihistamine. And what are all the antihistamines? Like we have diphenhydramine, doxylamine. These are all the various groups of drugs, and you should know what is the mechanism of action of these particular antihistamines causing the clinical features. These antihistamines like diphenhydramine and as well as doxylamine, they cause inhibition of central and postganglionic parasympathetic muscarinic cholinergic receptors. So they are your anticholinergic drugs. So what do? They block, right? They block this parasympathetic activity. That means they are acting as the anticholinergic drugs, right? Now, what will be the clinical features of the anticholinergic overactivity? They will have dry skin, dry mucous membrane, decreased bowel sounds, urinary retention. There can be myoclonus. These are all the features of the antihistaminic overdose. So now what do we want? See, these particular patients are having the excessive activity of, there is excessive anticholinergic activity in antihistaminic overdose. So what do we want now? We want the cholinergic activity to be increased. So in what is that particular drug which can increase the cholinergic activity is the physostigmine. Now this particular physostigmine is what? It is an acetylcholine esterase inhibitor. That means it will increase the acetylcholine. So thereby the anticholinergic symptoms will be reduced. So going back to this particular question now, right? So what is your doxylamine? That is antihistamine. What does this particular antihistamine doing? It is increasing the anticholinergic activity, right? But we want the cholinergic activity to be increased as a treatment part for the antihistamine overdose. So that is the reason why what will be the drug of choice here? The drug of choice will be physostigmine. The drug of choice will be physostigmine. Okay, so that was about your antihistamines. Now the next important group of drugs are, right, you see this question. What is the drug of choice for chlorpromazine induced ventricular tachyarrhythmias? Magnesium sulfate, lignocaine, amiodarone, sotalol. And again the question comes, what exactly is your chlorpromazine? So chlorpromazine, it is an antipsychotic drug. Right, chlorpromazine, it is an antipsychotic drug. Okay, now what is the mechanism? What are all the various antipsychotics? One includes your chlorpromazine, the other drug is olanzapine, next is quetiapine, then thioridazine. These are some of the antipsychotic drugs. Now what is the mechanism of action of these antipsychotics? The mechanism of action of these antipsychotics is they cause inhibition of alpha adrenergic activity, they cause inhibition of dopaminergic activity, they cause inhibition of histaminergic activity, and they also cause inhibition of serotonergic activity, right? And some of the agents, they also inhibit the potassium and as well as calcium channels. Okay, right. Now what is the answer here? Okay, so some of you have answered it as lignocaine. Now let me discuss and then come back to this particular question. So if you take this chlorpromazine, right, what exactly is that? It is an antipsychotic drug, right? So it causes the inhibition of the alpha adrenergic, dopaminergic, histaminergic and as well as muscarinic and serotonergic receptors. So like the individual will develop the features of the physiological depression. Now what will be the features of the physiological depression in case of the antipsychotic overdose? These are the features of the physiological depression, right? In grade 1, the individual will be lethargic or sleeping. In grade 2, the individual responds to pain but no voice. Grade 3, unresponsive to pain. And grade 4, unresponsive to pain, and there will be also flaccid paralysis. Okay, these will be the features of the antipsychotic overdose causing the physiological depression. Now the point that you have to understand here is, in case of, yeah, let me just go to that question. Right. So in case of the antipsychotic overdose, now what are all the activity which is being inhibited by your antipsychotics. Alpha adrenergic activity is inhibited, dopaminergic activity is inhibited, histaminergic activity is inhibited, and serotonergic activity is also inhibited, right? And because of all these, you know what the individual can develop? Because of all these, the individual can develop the QT prolongation in the ECG, right? The individual can develop the QT prolongation within the ECG. Okay, so antipsychotics are one group of drugs which can cause the QRS prolongation or QT prolongation. So once there is your QT prolongation or QRS prolongation, the individual will develop Torsades de Pointes, and for Torsades de Pointes, this will predispose the individual to develop polymorphic ventricular tachycardia. So once the individual develops polymorphic ventricular tachycardia, what is the drug of choice for QT prolongation induced arrhythmias? That will be the magnesium sulfate. That will be magnesium sulfate. It is not your lignocaine. Okay, so for Torsades de Pointes, the drug of choice will be the magnesium sulfate. And what are the other drugs? The other drugs will be your sodium bicarbonate. These are the other drugs. And in case of the antipsychotic overdose, what are the class of antiarrhythmic drugs which are avoided? Right? Which class of antiarrhythmic drugs are avoided? See, in case of the antipsychotic overdose causing QT prolongation, your class 1A, right, that is avoided. Class 1C, that is avoided. Class 3 antiarrhythmic drugs, these are avoided. Okay, so your amiodarone and all we don't give. They will, and even your sotalol also we don't give. They will further cause the QT prolongation. So the drug of choice here will be your magnesium sulfate. The drug of choice. So what is the drug of choice for chlorpromazine induced ventricular tachyarrhythmias? That is magnesium sulfate. What is your chlorpromazine? It's an antipsychotic. Why are we giving magnesium sulfate? Because this particular chlorpromazine, which is an antipsychotic, can cause inhibition of alpha adrenergic, dopaminergic, histaminergic, serotonergic and muscarinic receptors, causing QT prolongation, causing polymorphic ventricular tachycardia, which is nothing but Torsades de Pointes, for which we are giving magnesium sulfate as the drug of choice. And the other drug that can be given is sodium bicarbonate for the ventricular dysarrhythmias, can be given in case of antipsychotic overdose. Okay, right. So we have discussed two anticholinergic overdose activity. One is antihistamines, that is diphenhydramine and doxylamine. The other one is the antipsychotics. Okay, because antipsychotics also will inhibit the muscarinic activity. Right. Next is, okay, what is the drug of choice for Belladonna alkaloid poisoning? Physostigmine, acetylcholine, atropine, beta blockers. Yes, Harsh, for digoxin induced arrhythmias, yes, we give lignocaine. You are right. Right. So your Belladonna alkaloid, right? What exactly are your Belladonna alkaloids? The Belladonna alkaloids, right? Very simple question, not at all a difficult one. Right, very good, Sarika. So the drug of choice will be physostigmine. So what is your Belladonna alkaloids? The Belladonna alkaloids are atropine, then hyoscyamine, and then scopolamine. So these are your Belladonna alkaloids. Right, now what will be the mechanism of action of this Belladonna alkaloids? The mechanism of action of the Belladonna alkaloids is they cause the inhibition of central and postganglionic parasympathetic muscarinic cholinergic receptors. Right, so basically anticholinergic activity. Right, so they have the anticholinergic symptoms. What is that anticholinergic symptoms? Dry skin, dry mucous membrane, decreased bowel sounds, right, decreased bowel sounds, urinary retention, myoclonus. These are all the features of the excessive anticholinergic activity. Now what is that we want? We want the increased cholinergic activity, for which we give physostigmine, which is an acetylcholine esterase inhibitors, and they will increase the acetylcholine levels. And when do we give this physostigmine? Is mainly secondary to this atropine, like the individual can develop the delirium and hallucination. So that is the point when we can give this physostigmine. Okay, so physostigmine is considered as the drug of choice for the Belladonna alkaloid poisoning. Right, this is not at all a difficult question, very simple, and as well as the straight question. Now the next important anticholinergic is, right, answer this. Which among the following receptors are not blocked in tricyclic antidepressant overdose? right? Which among the following receptors are not blocked in tricyclic antidepressant overdose? That is alpha adrenergic receptors, dopaminergic receptors, histaminergic receptors, and inhibition of the calcium channels. Okay, so which of the following receptors or channels are not being blocked in case of tricyclic depressant overdose? Now, what are your tricyclic antidepressants? Right, very good, Karthik. So your tricyclic antidepressant overdose, it will not cause the inhibition of the calcium channels. And what are your tricyclic antidepressants? Very commonly used is the amitriptyline. The other drugs are doxepin. The other drugs are the imipramine, right? Amitriptyline, doxepin, and as well as the imipramine. Now, you should know what are all the receptors which are being inactivated by your tricyclic antidepressants. These tricyclic antidepressants, they cause the inhibition of adrenergic. They cause the inhibition of the dopaminergic. They cause the inhibition of the histaminergic, and they also cause the inhibition of the GABA activity, and they also cause the inhibition of the muscarinic receptors, and they also inhibit the serotonergic receptors. Okay, and very important point is this tricyclic antidepressant overdose, they will inhibit the sodium channels, right? They are the sodium channel blockers. They are sodium channel blockers. Which one? Tricyclic antidepressant overdose, not the calcium channel blockers. Now, what will be the clinical features because of your tricyclic antidepressant overdose? That will be physiological depression. And just now I have discussed what will be the features of the physiological depression, right? And not only that, because it is inhibiting alpha adrenergic, dopaminergic, and as well as serotonergic activity, there will be cardiac conduction delays, right? So what are all those? There will be increase in your PR interval. There will be increase in the QRS complex, widening of QRS complex. There will be QT interval prolongation. So these all will be the features of the tricyclic antidepressant overdose within the ECG. And not only that, there can be also right axis deviation. And the other features are the seizures and as well as the tachycardia. Now, whenever there is a tricyclic antidepressant overdose, what are the drugs that we give? The drugs that we give is the sodium bicarbonate for, right, that too a hypertonic sodium bicarbonate for ventricular tachyarrhythmias, which are associated with QRS prolongation. See, these drugs, they are causing the QRS prolongation. So secondary to QRS prolongation, there can be ventricular tachydysrhythmias, for which we give the hypertonic sodium bicarbonate, right? And what are the drugs which are being avoided? The drugs which are being avoided are the same drugs which are being avoided just now we have discussed. That is class 1A, class 1C, and class 3 antiarrhythmic drugs are avoided in case of the tricyclic antidepressant overdose. Okay, so what are the examples of this? Amitriptyline, doxepin, and as well as the imipramine. And the channels which are blocked by your tricyclic antidepressants is the sodium channels, but not the calcium channels. Okay, right. Then next is, yes, what is the drug of choice for clonidine induced hypotension? Drug of choice for clonidine induced hypotension: norepinephrine, atropine, naloxone, naltrexone. Okay, so first of all, you should know what exactly is your clonidine. First of all, you should understand what exactly is this clonidine. Now, this clonidine, it is an alpha 2 adrenergic agonist. Right, clonidine, it is an alpha 2 adrenergic agonist. Right, and we have many alpha 2 adrenergic agonists apart from clonidine. So apart from clonidine, we have tetrahydrozoline, and then imidazoline, and tizanidine. These are all your alpha adrenergic agonists, right? Now what they do, this particular clonidine or tizanidine or imidazoline, they stimulate the alpha 2 adrenergic receptors and thereby inhibiting central nervous system sympathetic outflow, right? They will, what these particular drugs, the clonidine will do, will inhibit the central nervous system sympathetic outflow, and thereby the individual can develop hypotension. And the other features like meiosis. Now the point is, for this particular hypotension which is caused by the clonidine, what is the drug that is being preferred? Very good. So the correct answer is, yeah, what are all your alpha 2 adrenergic agonists? The alpha 2 adrenergic agonist that includes clonidine, then tizanidine, then imidazolin, then tetrahydrozoline, right? Tetrahydrozoline. These are all your alpha adrenergic agonists, right? And what do? They stimulate the alpha 2 receptors, and thereby they will inhibit the central nervous system sympathetic outflow, causing meiosis and as well as the hypotension. And the drugs which are being preferred are the dopamine and as well as the norepinephrine. Dopamine and as well as norepinephrine. And these, because they are inhibiting central nervous system sympathetic outflow, there can be development of bradycardia, for which we give atropine, right? For which we give atropine. And the other drugs is that naloxone. Why? Because these drugs, this clonidine overdose or tizanidine overdose, can cause CNS depression. And for CNS depression caused by your clonidine or tizanidine overdose, we give naloxone, right? We give naloxone. So, right, very good, Harsh. So there can be transient hypertension as well, right? There can be transient hypertension whenever you stop the drugs abruptly, or when you stop the drugs, there can be even transient hypertension. That is nothing but your rebound hypertension can be there. Okay, right? So this is about your alpha 2 adrenergic agonist overdose, right? So these drugs, they come under what? Sympatholytics. They come under sympatholytics. Okay, now let me discuss one more sympatholytic overdose. Yes. What is the drug of choice for beta blocker overdose? Norepinephrine, glucagon, adrenaline, atropine. Drug of choice for the beta blocker overdose. Like we have cardioselective beta blockers and non-selective beta blockers. Which are your cardioselective beta blockers? Cardioselective beta blockers, that is beta 1 blockers, are the atenolol, esmolol, metoprolol. These are your cardioselective beta blockers. Then we have, right, we have beta 1 and as well as the beta 2 blockers, that is non-selective blockers. Non-selective are what? Propranolol, timolol, nadolol. These are non-selective beta blockers. Okay, right, very good. So the drug of choice is the glucagon. The drug of choice is glucagon. Now you should understand here, why is that we are giving glucagon? You should understand the mechanism of action of the glucagon. See, glucagon is the one which increases the heart rate and as well as the myocardial contractility, and it also improves the atrioventricular conduction. What does your beta blockers do? Beta blockers will block the AV node, and they also decrease the heart rate. What does the glucagon do? Glucagon will increase the heart rate and myocardial contractility, and that is the reason why we are giving glucagon as the drug of choice for the beta blocker overdose. Okay, so what is the mechanism of these particular drugs? They inhibit the beta adrenergic receptors. Now, what all will be the clinical features of the beta adrenergic blocker overdose? The clinical features of beta adrenergic blocker overdose is there will be physiological depression, there will be AV block causing bradycardia and bradyarrhythmias. There can be hypoglycemia, hyperkalemia, and as well as the seizures. Now, what is the drug of choice? That is your glucagon. So glucagon is the one which is given for hypotension and symptomatic bradycardia. Because of your beta blocker overdose, there can be bradycardia causing hypotension, for which we give glucagon. Then what about the other drugs, right? What about the other drugs? The options which has been given to you. You take norepinephrine, atropine, adrenaline. These drugs like atropine, dopamine, dobutamine, norepinephrine, epinephrine may sometimes be effective. These drugs, they are used only as an adjunctive drugs. Right, these drugs, they are used only as adjunctive drugs. But what is the drug of choice for beta blocker overdose? That is glucagon. Right, why is that we are giving glucagon as a drug of choice, even though we have sympathomimetic drugs like your norepinephrine and adrenaline is a sympathomimetic drug? But still, why are we giving your glucagon? That is because, see, the glucagon effect are unchanged by the presence of the beta receptor blocking drugs. Even though there is cardioselective blocking activity, even then the glucagon, what it will do, it will bypass the beta adrenergic receptor site, and thereby it increases the heart rate and as well as myocardial contractility. And that is the reason why we are giving glucagon as a drug of choice, not your norepinephrine, not your atropine, not your epinephrine. Okay, so that is the reason why we are giving the glucagon as a drug of choice. Now the next important is, yes, what is the drug of choice for verapamil overdose? Again, the same options: norepinephrine, glucagon, adrenaline, atropine. Yes, any one of you? No. Yes, any one of you? Right. It is not the norepinephrine or atropine. Right, very good, Harsh. It is again the glucagon itself. It is again glucagon itself. Yes, Dr. Reformer. What is the route of administration of this glucagon? See, this glucagon, it is an injectable agent. It is an injectable agent. It can be given through subcutaneous route. It can be given through the intramuscular route, or it can be given through the intravenous route as well, right? And what is the dosage of this particular drug, right? The dosage of this particular drug is around 1 milligram. Okay, yes, Dr. Reformer, is that clear? Now coming to the verapamil overdose. Verapamil is what? It is the calcium channel blocker, right? And what are the other calcium channel blockers like verapamil, diltiazem, and your nifedipine and all for hypertension? But your diltiazem and verapamil is the one which are given for tachyarrhythmias, right? They will reduce the heart rate. Now what are the channels which are being blocked by your verapamil? This verapamil will cause the inhibition of slow cardiovascular calcium channels. Now which are those slow cardiovascular calcium channels? They are nothing but your type L channels. That will be the very important multiple choice question here, right? So that is, they will block, this verapamil will block slow cardiovascular calcium channels, which are nothing but your type L channels. Now what will be the features of your calcium channel blocker overdose? Again, same story: physiological depression. There will be AV nodal block causing the bradyarrhythmias. There can be the hypotension, there can be ischemia and as well as infarction, right? And why is this particular ischemia and as well as infarction? That is because of your hypotension. When the heart rate reduces, definitely the blood pressure also reduces. Now what will be the drugs that you need to give? That is calcium and as well as glucagon should be given for hypotension and symptomatic bradycardia. Now what about the, what about the other drugs like your dopamine, epinephrine, norepinephrine, atropine, isoproterenol? They are less often effective, but they can be used adjunctively, right? Even in case of your verapamil overdose, the drug of choice will be glucagon. What about the other drugs? The other drugs, they are used only adjunctively. Which are those drugs? Dopamine, epinephrine, norepinephrine, atropine and as well as isoproterenol. They are less often effective but can be used adjunctively, right? So that is about the story of the verapamil overdose. So please remember now, beta blocker overdose and as well as the calcium channel blocker overdose like verapamil overdose, the drug of choice will be the glucagon, right? Please remember, this is a very important point. Next, now the next important is, right, yes, good evening everyone. Yeah, now this will be the last, this will be the last drug which I'll be discussing. Which of the following arrhythmia is not seen in the digoxin toxicity? Ventricular tachycardia, ventricular fibrillation, Mobitz type 2 AV block, ventricular ectopics. Yes, anyone? Right, so that is Mobit's type 2 AV block. That is not been seen in case of digoxin toxicity. And in digoxin toxicity, what will be the most common arrhythmia? The most common arrhythmia will be the ventricular bigeminy. That will be the most common ventricular arrhythmia. And the other arrhythmias that can be seen is VT and as well as VF and as well as the ventricular ectopics. And arrhythmias which are not seen with digoxin toxicity, right, not seen with digoxin toxicity, that will be the atrial fibrillation, then atrial flutter, right, and your Mobit's type 2 AV block. These are the arrhythmias not seen in case of digoxin toxicity. And even they can also cause, digoxin toxicity can also cause the bradyarrhythmias, causing the complete heart block, right, causing complete heart block. Now in case of, and this particular digoxin comes under which group of drug? It comes under your cardiac glycoside. It comes under your cardiac glycoside. And what are all the examples of your cardiac glycosides? That is digoxin and as well as the digitoxin. And what is the mechanism of action of this cardiac glycosides? Mechanism of action is the inhibition of cardiac sodium potassium ATPase membrane pump, right? So you have the sodium potassium ATPase membrane pump. This sodium potassium ATPase membrane pump will be inhibited by your cardiac glycoside overdose. Now what will be the clinical features? Again same story, physiological depression, but what will be the earliest manifestation? That will be the earliest manifestation will, in case of digoxin toxicity, will be nausea and as well as vomiting. That will be the earliest manifestation. And the other features will be in the form of the visual abnormalities, and that visual abnormalities is in the form of yellow vision. And because of the cardiac glycosides, the other important abnormality is the arrhythmias, just now we have discussed. And what will be the drug of choice in case of your digoxin toxicity? That is your digoxin specific antibody fragments, right, digoxin specific antibody fragments. And this particular digoxin specific antibody fragments should be given for hemodynamically compromising dysrhythmias, right? So this should be given where there is significant hypotension, right, where there is increase in respiratory rate, where there is fall in oxygen saturation. So hemodynamically compromising patients, here we give this particular digoxin specific antibody fragments. Okay, right. So, and what about the arrhythmias? For the digoxin induced tachyarrhythmias, the drug of choice will be lignocaine, right? The drug of choice will be lignocaine. Okay, and what is the other alternative drug? The other alternative drug to your lignocaine will be the phenytoin. That will be your phenytoin. So lignocaine or phenytoin can be given, right? And for bradyarrhythmias, I said you there can be development of your bradyarrhythmias. So for bradyarrhythmias, like what we give is the atropine, right? Bradyarrhythmias secondary to your digoxin toxicity, we give atropine, dopamine, epinephrine, and external cardiac pacing. Okay, so the other thing is the temporary pacemaker, or the individual may go to an extent of requirement of permanent pacemaker also, right? Now in spite of giving this the digoxin specific antibody fragments or lignocaine or phenytoin for ventricular arrhythmias, there will be refractory arrhythmias. Intermittently there will be development of arrhythmias. So in refractory cases, you need to place internal cardiac pacing and cardioversion. That means you need to place implantable cardioverter defibrillator. So implantable cardioverter defibrillator should be given for what? That is given for those individuals who are having refractory ventricular arrhythmias. In spite of giving your lignocaine or phenytoin, even we give magnesium also. In spite of that, if the ventricular arrhythmias are not subsiding, then we need to place the individual on the ICD. That is implantable cardioverter defibrillator, right? Yeah, Harsh. Okay, a very good question by Harsh. Now, sir, if both digibind and lignocaine is there in the options, what to choose? Now, let me tell you, just now I was discussing, right? We give this particular digibind, we give this digibind whenever the individual is hemodynamically compromised. Whenever the individual is hemodynamically compromised, like when there is hypotension, we give this digibind. Okay, we give this digibind. Understood? And whereas lignocaine, if the individual is hemodynamically compromised with ventricular arrhythmias, we don't give lignocaine. There it is your DC cardioversion will be the treatment of choice. Okay, so hemodynamically stable ventricular arrhythmia, then you give lignocaine. Hemodynamically compromised, then we give your DG binder. Yes, Harsh Ketan, is this clear for you? Right. And yes, Sandeep Saini. So, like, what is the most specific arrhythmia in digoxin overdose? Right? I said you already. Okay. So, this will be the most specific arrhythmia that you will come across in case of the digoxin overdose. That is ventricular bigeminy. Ventricular bigeminy. That will be the most common arrhythmia that you will come across. So that is the reason why even in digoxin toxicity, what will be the characteristic pulse? The characteristic pulse will be pulsus bigeminus. Right? The characteristic pulse will be pulsus bigeminus. That is what you will see in case of digoxin overdose. Okay, so this completes the discussion of the drug overdose and as well as treatment. Right, I have just discussed few drugs, few more drugs I'll discuss in further sessions. Right, so the PDF of this particular channel, sorry, the PDF of this particular session will be available to you in the DBMCI Premier Group Telegram channel, or it will be available in my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Right, so thank you very much. See you in the upcoming sessions.